welcome. My name is Dr. Ari Isaacson from the IR Centers in Raleigh, and I want to thank you for joining us tonight for this webinar. If you were looking forward to it last week, I apologize. I had something come up, a little illness that unfortunately caused us to reschedule, but I'm grateful that you're here with us tonight. The presentation tonight is called Relief Without Surgery, and I'll be talking about genicular artery embolization to treat knee pain as a result of arthritis. The format for tonight is I have a slide presentation, but if you have questions as I'm talking, feel free to put them in the chat. I won't address them till the very end, and I'll go through every question and give you the answers, okay? All right, let's get started. So first, a lot of people don't know what interventional radiology is, or an IR center. So IR centers, IR stands for interventional radiology. That's my specialty within medicine. And what that is a subspecialty of radiology where you actually do minimally invasive procedures using imaging guidance to help those procedures. And so my training was first in diagnostic radiology, and then I did a fellowship in interventional radiology. And a lot of the ways that I describe it is, way cardiologists will go into arteries and treat diseases in the heart and in arteries, coronary arteries. We do similar things, just in different parts of the body. So instead of just looking at images like diagnostic radiologists, we actually intervene. That's why it's interventional radiology, and treat people through their arteries and veins. So a little backstory on genicular artery embolization. This was a procedure that was initially developed in Japan, and back around 2014, so about 12 years ago, myself and a couple other interventional radiologists decided that we were going to do the first US clinical trial on this particular procedure. And so we did a partnership between, I was at the University of North Carolina, and also with other institutions. And we created a clinical trial to test genicular artery embolization. We actually did two trials. The first one just evaluated its efficacy, period. And then the second trial, we actually compared it to a sham procedure. So we had a control arm, which is a very rigorous way to evaluate a procedure. And it turned out to be a lot superior to the sham or to the placebo. So I was one of the first in the United States to actually do this procedure. All right, let's pivot a little bit to talk about knee pain. So, as you know, you're probably here because you have knee pain, and so it's very common. The most common etiology is osteoarthritis, and we'll get into what causes the pain a little bit later, but that's the most common diagnosis. And ultimately, what it leads to is a lot of knee replacements. People end up running out of options for treatment and ultimately get their knee replaced. And knee replacement can be very good. I'm sure everyone knows someone who had their knee replaced and it turned out really well. But it is a big surgery, and there's some disadvantages to doing it too early. The implant can occasionally wear out. And so a lot of times we try to delay that by doing other treatments. So that results in the treatment gap. So what is the treatment gap? That's what we can do to delay the need for a total knee replacement. And GAE is actually really helpful for that. So let's talk a little bit about some of the treatments for knee pain. So initially, when you have knee pain, you start with things like just wrapping it, icing it, taking medications, maybe do physical therapy. And then you might progress to some kind of knee injection. And those injections include steroids, something called hyaluronic acid, or Synvisc is the brand name. And lately, platelet-rich plasma has become more popular, although it's still not paid for by insurance. And then stem cells. Some people are also getting stem cells injected. So there's all sorts of injections that are available. Well, if you've had steroid injections, they can work for a while, but they tend to not last super long. And Synvisc is similar, or hyaluronic acid can help for a while, but those eventually will wear off and not work. And so what then? So either at that point, you're either ready for knee replacement, or you could consider genicular artery embolization. All right, so let's talk about why this procedure would work. So in order to do that, you have to understand a little bit about the pathology associated with osteoarthritis. Everyone just thinks that osteoarthritis is the loss of cartilage, and that is true, but that's not what's causing the major pain in the knee. It starts with the cartilage breaking down, and if you can see this image here, I'm try to follow it a little bit. You have initial breakdown of cartilage. What happens then is messages get sent over to the lining of the knee, which is called the synovium. Inside the synovium, there are lots of inflammatory cells that then get revved up and start sending out messages to increase the inflammation. And what happens as a result of that inflammation is new arteries grow, little micro arteries. And next to those arteries, you have new nerves as well. And so these aren't nerves and arteries that you were born with. These are nerves that have and arteries that have grown in response to the chronic inflammation in the knee that was started by the breakdown of cartilage. And so that's really what's going on inside the knee. And so it's not just the rubbing, it's not a mechanical rubbing of one bone on another that's causing the pain. It's this chronic inflammation and new arteries and nerves that have grown in the lining of the knee. And so that's what we're addressing with this procedure. So just to be clear, GAE, genicular artery embolization, doesn't regrow cartilage. It doesn't fix arthritis. It's just to reduce pain, similar to a steroid injection, in order to delay the need for knee replacement. All right, so as far as the evidence for GAE, multiple studies have been done at this point. So we did our first study 12 years ago. During that 12 years, there's been studies done in many countries looking at this. And what we tend to see is that when someone says what their pain is on a scale from 1 to 10, we see a 60 to 80% improvement over a 6 to 24 month period in different studies. So you can think about, I think it's more reasonable that the more expected outcome is maybe to have your pain cut in half. So if someone comes in and they say, well, my worst pain is 8 out of 10 when I'm squatting or going upstairs, then what we would hope for after the procedure is maybe 4 out of 10 doing those same activities. The other thing about this procedure is it's very safe. We see very minimal complications. Some of those that we do see are sometimes you can have a rash that develops afterwards, or there can be worsened pain for a week afterwards, but the complications are mild and minimal. All right, so to understand GAE a little bit more, I'm going to show you a picture or a video of the procedure in just a minute, but it's a very precise procedure. We're targeting very precise vessels. So you might say, well, how can you block arteries in the knee? You can only do that if you're leaving the big ones open and you're just blocking the little microvessels that we were talking about earlier. And basically what we're doing is we're turning down the amount of fuel there is to fire the inflammation inside the knee joint, which was what results in the decrease in pain, and the fact that that decrease in pain can persist for, we see up to 2-3 years sometimes for some patients. And it's a same-day procedure, so it doesn't require overnight stay in the hospital. And we don't put you to sleep for it. You're awake. It's not a painful procedure. And so I'll give you a little bit more detail as we move on. All right, so at this point, we have a video that we're going to show about the procedure, so I'll kind of narrate. So what happens is we access the artery in the groin area. So in this case, we're treating the right knee, so we access the left side. We run a catheter down the artery. As we get down towards the knee, we do some angiography, and I'll show you some pictures of that in a second. Then we put a microcatheter in, select very specific arteries where the knee pain is, and inject these little beads that block off those microvessels that I was talking about before. And so when we're done, those microvessels are no longer present, or you can't see them anymore, and that's what results in the improvement of pain. Let's run that back one more time, just so we can see it one more time. So once again, accessing the artery in the groin, we do a little numbing shot here before we put it in, so you really don't feel much. and you really can't feel anything inside the artery, so you're not even going to know that the catheter is traversing your artery. And then when we get down here, we'll put a microcatheter through the first catheter. So there's that little microcatheter. We'll find the area of pain that you've reported to us, and then focus on that area to block off the microvessels in that area. All right. Okay, so just a step-by-step on what we do again. So we get into the arteries, we map the knee, meaning we inject contrast dye under x-ray to show us all of the arteries in the knee. Then we will, when the patient comes in, they say, well, my pain's mostly on the inside of the knee, or it's on the outside of the knee. So we kind of have an idea of where we're looking, and we go towards that direction. So the most common is the medial or inside of the knee. And so we'll focus on the arteries in that area. We then put that microcatheter in and very, very precisely target the micro vessels in that area and block those. Again, we're not blocking the main arteries, we're just blocking the micro vessels. And then after a week or two, patients start to feel some improvement in their pain. And typically the procedure takes about an hour or so. That's pretty typical. All right, so let's go through some pictures from an actual case. So this is what I'm looking at when I see when I'm looking at the x-ray pictures. So we've injected contrast here, and what we're looking for are areas of what we call blush or smudginess. And that blush or smudginess represents those microvessels. So if you look at the top left image, you can see some smudginess midway through the knee. And then when you go to the top right image, this would be after we've put the particles in that we embolize with. Now that smudginess is gone. The main vessel is still there, we can see it, but the smudginess has disappeared. Similarly, on the bottom left image, you can see a smudginess just at the bottom of the bone on the left side. And then if you look at the image on the right, that's after embolization, that smudginess is no longer present. So that's what we're trying to do when we do the procedure. Here's just an angiogram. So when we inject contrast in the artery, this is what it looks like. That's our x-ray picture when we inject. So we're seeing all the arteries. That's what the mapping looks like. Okay, and again, just showing you the smudginess again, same deal. Again, you can really see the smudginess in this right image, and then on the left image, it's no longer there. And again, you can see that again, it's not there anymore. Again, smudginess, and this would be a big mapping image where we can see some smudginess on the left aspect of the knee there, and then selecting that specific artery to target that area of smudginess again. All right. So who's a good candidate for this procedure? Well, the best candidates are those that have already kind of tried the conservative stuff, the physical therapy, medications, injections, and they have mild to moderate OA. We can do this procedure for severe OA, but we have found that mild to moderate OA tends to respond better. We want patients mainly that have an area of the knee where they can tell us their pain is located. If you say, well, my pain is everywhere throughout my knee, that's harder to deal with because we don't know where to look first. If the pain is on the inside of the knee or the outside of the knee, then we can focus on it better. And then the other thing is for patients that are not quite ready to have a knee replacement. So that's kind of who we're looking at. All right, so what to expect if you come in for this procedure. So you would come into the office. We do cases in the morning. We would check you in, have you change into a gown, place an IV on you and attach and hook you up to the monitor, give you a couple medications. We would offer you Valium if you'd like it. You don't have to have it, but that would just take the edge off. You will be awake during the procedure, so if you prefer to have the Valium, you can go either way. But we do not put patients to sleep for this procedure. We'll make a little pinhole in either in the upper thigh. It'll either be on the right or the left, depending which knee we're going into. And we'll do the procedure. It usually takes about an hour, like I said. And then afterwards, we'll monitor you for usually around 90 minutes. And after that 90 minutes are up, you'll go home. And so usually you're in our center for about 3 hours total for the procedure. After the procedure is over, for the first couple days, you may have increased soreness in your knee as well as at the area where we entered the vein or the artery. But that should get better after a few days. After a week or two, you'll probably start to notice some minor improvement, and then it'll increase more out at 1 month. From months 2 to 6, patients tend to feel better and start doing more activities. There is one warning I tell patients here is that a lot of times they feel a lot better and just jump into a lot of activities that they haven't done in a long time. And that can be trouble, that can cause more pain. So we just try to warn patients, take it easy, let's ease back into activities and not necessarily jump right back into really hard stuff. All right, what do clinical results show? So we kind of mentioned this before, about 80% in clinical trials report some degree of improvement in their pain. Again, pain score drop, I think, is about 50, 60%. And then when the relief starts, it tends to be about a month afterwards. Is it safe? That's a big question. It's very safe. We see very few side effects in these trials. Again, we see the skin rash can happen, but it's just temporary. It'll get better. And so that's really the main one. So there's not a whole lot that can go wrong. I will tell you that some cases, occasionally, because of the way the arteries are, we can't get into an artery that we wanted to get into, and that can affect the degree of improvement that we see in pain. So that's something else that can happen as well. But it is a very safe procedure. So how does GAE compare to other options? Well, compared to medications, I would say it lasts longer and there's less side effects associated. Like if you take NSAIDs or ibuprofen a lot, that can affect your stomach or your kidneys. And then if you're taking Tylenol, that can affect your liver. So even medications have side effects. GAE, I would say, has less side effects than that. As compared to steroid injection, it tends to last longer than steroid injection, which is nice. And then I wouldn't compare it to knee replacement because that's a more a durable and permanent type of treatment, but it is a bigger surgery and that has its own risks. All right, so why would you come to me or our center for this procedure? There are other places that offer it. It's because we have been doing the research on this for a long time and kind of been the leaders in bringing it to this country. We're just finishing up another trial where I'm the principal investigator for the trial, so still doing the research. And you might say, well, why are you still doing research on this? The research is based on a new particle that has come out. So in order for that particle to come to market, it has to go through research. And that's what we're doing with this procedure. And so we do this often, and so we have standardized it. And when you come to see us, we'll let you know if we think you're a good candidate or not. And so you don't have to worry about being sold on a procedure you don't need. All right, so what are the next steps? Next steps would be to, if you have imaging already, to bring it with you, to schedule a consultation, and we would see you and then come up with whether or not this would be a good plan for you. All right, so a little encouragement. If you're living with knee pain, you may have more options than you think. If you weren't familiar with GAE, I think this could be a real helpful procedure for you. So something to think about. And at this point, I'll start looking at the questions. All right, so the first question I have is, does the IR Center perform spine procedures or does GAE apply only to knees? So we don't do this for spine, but GAE does not apply only to knees. The same concept can be applied to other body parts like shoulders or hips or elbows. But spine is a tricky one. And the reason is because the spinal cord is there. And so there is a higher risk of causing a decreased blood flow to the spinal cord, which could be very serious. So we don't do it for spine, but we do it for other areas of the body. So that, I think, answered maybe the second question, which can we do it for hip pain? We can. In fact, there are only certain types of hip pain that respond to it, but we can do it for hip pain. And that's something we could see you for and evaluate. Is it approved by insurance? It is in many cases, and so that's something we would figure out if you came to see us to be evaluated for it, we would submit to the insurance company and make sure it was approved before we moved forward. And many insurance companies do pay for it. What is the smudginess? So what I was talking about smudginess, again, that was just the appearance of the microvessels, the tiny arteries that grow in response to the inflammation. So that's the appearance of those vessels when we do our X-ray images, and that's what I was calling smudginess. How is it connected with urologists? That's a good question. It isn't connected with urologists. I happen to work at IR Centers, which happens to be part of the Associated Urologists of North Carolina. And so this is a service that we offer. And so it's not a urology thing, but it's part of IR Centers. Can GAE be applied to hand arthritis? It actually can. We haven't done that yet, but there have been data, there's research that has shown that it can treat hand arthritis as well. I have had gel and steroid shots and they did nothing for me. Does that have any correlation with what you do with GAE? And are the images you want an MRI or regular X-ray? We haven't really done the research to know if the steroid shots and the gel, if they correlate, meaning if you have improvement from that, you're going to have improvement from GAE. So the answer is I don't know that for certain. My thought would be if you're interested, to just see what your knee pain is like, hear your story, when does it hurt, where does it hurt, all that stuff, and try to understand. And then I would give you my best idea if I think it would be helpful. Are the images you want MRI or regular X-ray? MRI would be great. If you have an MRI, that would be very helpful. If you have an X-ray, would like to look at that as well. The X-ray can show us a lot about arthritis, and MRI can show us more about the menisci and the ligaments and such. So we don't require an MRI prior, but if you have one, that would be helpful. All right, can you return to running or other high impact exercise? I think you can, as long as you don't do it very quickly. I think you need to slowly work yourself into it and let the muscles develop around the knee again, since you haven't been doing those things in a while. So I think it is possible to return to high impact stuff if you do it slowly. Is it recommended for those over 90 years old? There's no age limit because it's such a safe procedure. We can do it for people who are over 90. However, I will say that the people who are over 90 tend to have more issues with their arteries just because of age. So that can limit the effectiveness of the procedure if it's difficult to manipulate the catheter through the arteries. But just age in itself doesn't limit the efficacy or the function of a GAE. How long does a GAE last? So what we know is if someone responds, we said 80% of people respond. So if you're a responder, if you're one of those 80%, then about 80% of those people actually have some improvement out to 2 years. How much longer can it last? We don't really know because we don't have research that goes a lot further than that. But we know that there are a lot of patients who still have improved pain at 2 years. I have full knee replacement and still have pain using stairs and bending. Is GAE helpful for me? We have seen this in some circumstances. So we have done patients who've come in who've had a total knee already, and we're trying to help them with their residual pain. I would say it's not as effective as if you're coming in without a knee replacement, meaning it's not an 80% improvement. In my experience, it's been more of like a 60, 70%. But a lot of times when you've had a knee replacement, there isn't a whole lot you can do anymore. So you're kind of grasping for whatever. And so it may be worthwhile to look at this procedure because it is so safe. It's not too much of a risk to do, even though the efficacy is a little bit lower. Is there a certain weight range? No, there's no weight range specifically. Just like with anything else, it's gonna, if you're able to drop some pounds, it's gonna take a lot of load off your knee, and that's gonna help your pain. But there's no weight range for this procedure. We don't have a limit. What happens to the materials injected? Other material that is removed, where does it go? The material that is injected, we either use a temporary or permanent particle, depending on kind of what is present, what we have in stock. If it's temporary, it will get absorbed. If it's permanent, it'll stay there. The permanent particles that we use for other functions, other treatments as well. And so we've been using them for a while. So we know that they're safe, that they don't cause any issues with having a foreign body or anything like that. They are non-reactive with the body. And so, they're safe to use. We don't remove any material. Nothing's being removed. We're just blocking blood flow to very specific microvessels. That's the goal of the procedure. My knee issues are not pain but weakness. Might this apply? No, I don't think so. When it's just weakness, then the whole reasoning for why this procedure might work doesn't seem to apply. So I would say no to that. Can the procedure be done on both knees at the same time? No, we don't do both knees at the same time. We would do one and let that one get a little better, and then we would do the other. So one at a time. All right, I think I made it down to the bottom of the list here. So I'm going to go one more screen here, and this is how you can get a hold of us. If you're interested in learning more and want to have your knee evaluated, you can call us at this number or use the QR code there, and we can schedule a consultation and give you what we think. Again, it's not for everyone, but it can help a lot of people, and we'd be grateful to have the opportunity to see you and look at your knee and give you that advice. All right. Okay, I want to thank everyone for taking the time out of their evening to join us, and we will also be sending this the recording of this webinar to your email. So if there's something you missed earlier, you'll be able to watch the recording. All right, have a good night. Take care.